My name is Ben Grass, and this is the Toxicology of Testosterone. Testosterone is the principal androgenic steroid and is produced in males mainly in the testes. In females, smaller amounts of testosterone are produced by the ovary and the adrenal gland. It is the primary sex hormone in males and is responsible mainly for the development of sexual characteristics. It is present in both males and females across an array of species, and it is produced naturally. It can also be administered synthetically via intramuscular injection, more commonly known as anabolic steroids. Testosterone is likely to come into contact with humans for one of two reasons. 1. It is injected for athletic performance-enhancing purposes, or 2. As a therapeutic use as it relates to hormone therapy of a known health disorder. Testosterone can be administered in many ways, but I will focus on the most common method being intramuscular injection. Intramuscular injection bypasses the epidermis directly into deep striated muscle tissue where rich blood flow is present. Most common and effective sites where injection occurs are buttocks, natural surface of the thigh, lateral surface of the thigh, deltoid region, and all three of these sites are near major blood vessels. As you can see here, this is the structure of testosterone, and it contains two main functional groups. One is a ketone and the other is an alcohol. Both of these functional groups are mediocrely polar, but due to the chemical properties of the steroid hormones, it is nonpolar. Testosterone has a log POW of 3.32, which is well within the toxin drug likeness range, with strong hydrophobic properties for absorption across membranes. It has a pKa of 19.09, and due to this pKa value, testosterone will remain protonated. The distribution. Testosterone is administered by intramuscular injection, which bypasses regular routes of absorption. This method introduces the toxin deep within striated muscle tissue where rich blood flow is present. The toxin then enters systemic circulation in the bloodstream without any metabolism occurring. This is the diagram of the cardiovascular system, and due to the different sites of absorption where the intramuscular injections would occur, it will either enter the trunk and the legs by the iliac artery, or it will enter the carotid artery by the shoulder, deltoid. Both of these regions will result in systemic circulation, and will end up through the iliac vein to the inferior vena cava, into the heart, up through the lungs, back into the heart, and then will be distributed via the aorta or the carotid artery, where it will exert its toxic effects without even reaching the liver yet. The metabolism of testosterone occurs in the liver. Metabolism of the steroid molecule involves reduction, hydroxylation, oxidation, epimerization, and the formation of conjugates. Different reactions occur on each of the four rings of the steroid molecule. The different rings are identified as the A, B, C, and D rings. There is an immense amount of pathways in the metabolism of testosterone, with solid research evidence supporting each path. This research has been funded and performed because testosterone metabolites must be known for detection in urine samples of athlete anti-doping procedures. In phase 1 of metabolism, with the A ring, involves 5-alpha and 5-beta reduction, 3-alpha and 3-beta hydroxy reduction, 1,2 hydrogenation of 3-keto-androst 1,4-diene steroid, 1,2 dehydrogenation of 3-keto-4-ene steroids. And with B ring metabolism, consists of 6-beta hydroxylation and 6,7 dehydrogenation. C ring metabolism is very modest, and therefore only one reaction is thought to happen, which is 12 hydroxylation. On the D ring, however, has the most different reactions, containing of 17 oxidation of the 17 beta hydroxy group, 17 beta hydroxylation of 17 keto steroids, 17 alpha hydroxylation of 17 keto steroids, 16 alpha and 16 beta hydroxylation, 16 oxidation, 17 epimerization, and 18 and 19 hydroxylation. The phase 1 metabolites make it so that phase 2 metabolism can occur more easily. The phase 2 metabolism of testosterone involves the conjugation of either the steroid itself or its metabolites with glucuronic acid or sulfate. These conjugation reactions helps with the elimination of the steroid from the body, and both conjugation reactions are enzymatically controlled. After metabolism in the liver, some metabolites as well as some free testosterone will enter the intestines via bile ducts and continue along the path to excretion. Excretion is not metabolism dependent, however. About 90% of a dose of testosterone given intramuscularly is excreted in the urine as glucuronic and sulfuric acid conjugates of testosterone and its metabolites. About 6% of a dose is excreted in the feces, mostly in the unconjugated forms. When performance anti-doping tests on athletes, they use a urine test because that's where 90% of the dose is excreted. They not only test for free testosterone, which is T, but they also test for all known T metabolites. For every molecule of testosterone produced in the body, another molecule of a substance called epitestosterone is made. The T to E ratio that causes an athlete to fail a doping test is 4:1. The parent toxin, free testosterone, or T, exerts the toxic effect of testosterone, but one metabolite, DHT, binds to the same androgen receptor even more strongly than T, so that its androgenic potency is about 2.5 of that of T. The target molecule in the body is the androgen receptor. The steroid hormone and their receptors are involved in the regulation of eukaryotic gene expression and affect cellular proliferation and differentiation in target tissues, activated but not phosphorylated by HIP-K3. The target tissue in the body is the testes. Testosterone will exert its effects on the testes of males, which can cause suppression of gonadal steroidal genesis, testicular atrophy, and disproportionate growth of the inner prostate. The mechanisms in which testosterone exerts its toxic effect are, at the genetic level, by activating cell surface receptors, influencing signaling cascades, and causing changes in gene transcription. The effects of testosterone in humans and other vertebrates occur by one of two main mechanisms: by activation of the androgen receptor, directly or as DHT, and by conversion to estradiol, which is also estrogen, and activation of certain estrogen receptors. Free testosterone, T, is transported into the cytoplasm of target tissue cells, where it can bind to the androgen receptor, or it can be reduced to 5-alpha dihydrotestosterone, DHT, by the cytoplasmic enzyme 5-alpha reductase. DHT binds to the same androgen receptor even more strongly than T, so that its androgenic potency is about 2.5 that of T. The T receptor or DHT receptor complex undergoes a structural change that allows it to move into the cell nucleus and bind directly to a specific nucleotide sequence of the chromosomal DNA. The areas of binding are called hormone response elements, or HREs, and influence transcriptional activity of certain genes, producing the androgen effects. The negative effects of testosterone are as follows. In men, anabolic steroids can reduce sperm count, shrink the testicles, cause you not to be able to father children, enlarge the breasts. In women, anabolic steroids can increase body hair, make skin rough, decrease breast sizes, enlarge the clitoris, and deepen the voice. In both men and women, anabolic steroids can cause bone growth to stop before it's complete in a teen. The teen may not be able to reach his or her full adult height. A heart attack or stroke, even in a very young person. High blood pressure, higher levels of bad cholesterol than lower levels of good cholesterol, liver disease and possibly liver cancer, oily skin and acne, male pattern hair loss, skin infections that may become severe if the drug was tainted with bacteria, irritability, rage, uncontrollable high energy, and false beliefs. Testosterone treatment is most common in men because it is a very prominent hormone in male physiology. Testosterone therapy is used to treat or help improve well-being while dealing with many disorders such as sexual dysfunction, low bone density, body composition and muscle strength, cognitive and psychological impairment, HIV and AIDS, prostate disease, cardiovascular disease, and polycythemia. Many, but not all, of these disorders are a direct result of hypogonadal men, which result in low T levels. These are my references. Thank you.